Hello, I am Dr. Yusuf, Assistant Professor Pediatric Surgery, ABU. I am going to discuss today anorectal malformations from a general surgery resident's point of view. Well, to begin with, we'll be discussing it under the contents, introduction, embryology, genetics, incidence, classification, and how to approach. As resident, at many times you will get a call by a pediatrician in the emergency that a baby is born with no anal opening, or a baby is born in which the anal opening is opening in the middle of the scrotum, or it is opening below the scrotum like a skin tag, or the opening is just below the vagina. What are all they? They are all called as anorectal malformation, a complex group of congenital anomalies in which there is abnormal communication between the anus, rectum on one hand, and the urinary and the genital tract on the other hand. Well, embryologically, there is an abnormal development of the urorectal septum in the fetus growth, which normally separates the hindgut from the urogenital sinus. So, if this development is abnormal, that will lead to anorectal malformation. ARM can be non-syndromic, occurring sporadically, just without any cause, or it can occur in families, or can be associated with syndromes. The more common are the Bactrial, OIS, Currarino, or the Down syndrome. Bactrial is nothing but an acronym for vertebral anomalies, anorectal malformation, tracheoesophageal fistula, renal and limb anomalies, which occurs in up to 50% of cases. Also, ARM, in most of the cases, it doesn't occur alone. It does have anomalies in other systems, mainly the cardiovascular, gastrointestinal, renal, and the genitourinary system, in up to 70% of cases. Anorectal malformations are classified using the wing spread classification, in which the lesion is decided whether it is high or low or intermediate based on the position of the levator anal muscle. If it is high, the management is different. Low than the levator anal muscle, the management is different. But it had a drawback that it didn't include the rare cases which were prevalent in the Indian subcontinent. Hence, another classification came up in 2005, known as the Kickenberg classification. It had a significant contribution by our pioneered Indian pediatric surgeons, and it was based whether it is major or minor, and the rare cases were included. Incidence-wise, it is slightly higher in males. It occurs in 2 to 2.5 cases per 10,000 live births. Anomalies, everything is more common in males. Anatomy, if you talk about, so this is the normal rectum, anal canal, opens in the circular muscle sphincter. But what happens in a case of anorectal malformation, you can see the rectum and the anus are opening anterior to the muscle complex. Or it can be scenario in which they are opening at variable lengths into the urinary tract, or altogether they will be opening into the urinary bladder. So how to approach? Very, very important as a resident when a patient encountered resuscitation. Determine the level of the anomaly, associated anomalies. So, what is resuscitation? You have to put a nasogastric tube, catheterize the patient, establish an IV line, IV fluids, IV antibiotics, keep the baby warm, sugar monitoring, and then rule out other anomalies, and then reevaluate after 24 hours again, along with radiological investigations. What we order? An X-ray abdomen erect, supine, if we have to see the gas pattern and the vertebral column. And then the very important, which every surgical resident has to know, is the cross-table lateral prone film, in which we have to put a cloth below the patient. Patient is in a prone position. X-ray film is kept behind. X-ray beam is focused on the trochanterus. You will get an X-ray film like this. An imaginary line between the symphysis pubis and the coccyx is drawn, known as PC line, and we see the gas shadow. If it is below it, means low ARM, above it, high ARM. That means it is the level of the levator anal muscle. So, how to proceed again? Resuscitation, we have evaluated, waited for 24 hours, and then if it is a perineal fistula, how you proceed? If it is an opening, high or low, how you proceed? If it is a perineal fistula, which is an opening into the perineum, all you need to do is just expand the edges so that it will facilitate in the outcome of the fecal, and that's it. Or if it is high, then you have to do a colostomy. you have to high divide sigmoid colostomy, in which you have to make opening in the abdominal wall as shown here. But the concept is you have to keep distally a significant limb so that it will help later on the definitive management. Definitive management includes the posterior sagittal and rectoplasty. We have to keep the baby prone. The principle is you have to give a midline incision, identify the new anus site using electrical stimulator, identify the rectum, pull it into its new position. Likewise in females, you have to, after resuscitation, stabilization, if it's a single opening, means Kulveka managed by colostomy. If perineal fistula anoplasty, other than that, you have to manage by colostomy. What is Kulveka? A common channel in which the urinary bladder, vagina, and rectum open into one channel. Pouch colon, why it is important? It is frequent in North India, in which part of the colon or the entire thing is replaced by dilatation, which is opening into the genital system. Another entity common in South India, rectal atresia, baby is born, abdominal distension, normal anal opening but has not passed as meconium. What you need to do is just take a feeding tube, put it per rectum, it will not pass beyond 2 cm. This is the hallmark for diagnosis, and it is established managed by colostomy. Post-operatively, all cases of ARM, once the new anus has been developed, it has to be dilated using Hager dilator until the desired size has been reached, followed by the stomach closure, which we have made earlier. Outcomes in a case of ARM is managed, assessed by using voluntary movement, soiling, and constipation. Other aspects they have to include the urinary section and the long-term growth and development. Like, they are all dogs, but each dog is unique. Each case of ARM is unique in its presentation and management. Thank you.